Good evening, folks. Welcome to SUPERPoints. Again, we would like to discuss pathology, extremely important topics. And let us start with this question today. A 6-month-old is brought to the pediatrician with a history of recurrent pneumonia, thrush, and chronic diarrhea. Physical examination reveals failure to thrive and absent tonsillar tissue. Laboratory studies show profound lymphopenia with markedly decreased T and B lymphocytes. Genetic testing confirms a defect in the common gamma chain of the interleukin-2 receptor. Which of the following best describes the pathological findings expected in this patient's condition? So we have like 4 options here. Go through those options and choose the best answer. So the best answer here is B. Let us see this very important topic. Why it's B? First of all, understand the topic. What are they talking about? This is severe combined immunodeficiency, primary defect of both T and B cell immunity. Severe combined immunodeficiency is a life-threatening primary immunodeficiency disorder characterized by profound defects in both cell-mediated T cell and humoral B cell immunity. It most commonly results from mutations in the common gamma chain interleukin-2 receptor gamma subunit, which is shared by multiple interleukin receptors IL-2, 4, 7, 9, 15, 21, and is essential for lymphocyte development and survival. So, SCID is primary failure of both T cell and B cell immunity. There are genetic defects here. So what is happening? The name itself is a big clue. Severe combined, right? Severe. So there are severe infections combined. That is, there is a T cell defect and B cell defect. So what is happening because of B cell defect? The antibody production decreased. So these infants are highly exposed are at high risk for bacterial, fungal, and viral infections because plasma cells are not producing enough antibodies. And their T cells are also defective. There is no memory T cells. There are no memory B cells. What is happening? You're getting same infections with the same severity. So the clinical manifestations would be failure to thrive, hypoplastic tonsils and lymph nodes. There is persistent oral thrush, recurrent infections happening, chronic diarrhea, there is recurrent pneumonia happening. So the best clue here is absent thymic shadow. There is no thymus shadow there, all right? So thymus being a very important organ in T cell production and maturation, it is absent. So that's a very good clue in your examination. Because T cell maturation fails, B cell function is also impaired, leading to near complete immune incompetence. Infants typically present in the first months of life with recurrent severe bacterial, viral, fungal infections, persistent thrush and chronic diarrhea, failure to thrive, marked lymphopenia, and there is this hallmark, absent thymic shadow and chest X-ray, hypoplastic lymph nodes and tonsils. Without early treatment, SCID is fatal. So how do I remember this? The mnemonic I used is SCID. Just use the name itself. S for severe infections, C for combined immune defect, I for infant, right? I for infant, and D for decreased thymus. So use the D for the decreased thymus, absent thymic shadow. Why not other options? All right. Listen to incorrect answers because there is so many things you can learn from incorrect answers. For example, why not A? Lymphoid depletion due to HIV infection and CD4 T cells with opportunistic infections. And it describes AIDS caused by HIV mediated CD4 T cell destruction. This occurs later in life and does not present early in infancy with absent thymus or congenital lymphopenia. Why not C? Chronic granulomatous inflammation due to defective NADPH oxidase in neutrophils. Whenever you see this one, defective NADPH, think about chronic granulomatous disease. And that is a phagocyte oxidative burst defect. Patients have recurrent catalase positive bacterial fungal infections, but normal T and B cell numbers and intact thymic development. And why not D? D is autoimmune hemolytic anemia and thrombocytopenia due to loss of self-tolerance. And this describes autoimmune disorders, autoimmune cytopenias, ALPs. These involve immune dysregulation, not global immunodeficiency with absent lymphoid tissue. So super formula for this topic is, like super formula is how you can see a few keywords and go to the answer in a few seconds. All right. What can you see in this question? You see an infant. The infant has recurrent severe bacterial, viral, fungal infections. There is common gamma chain defect. There is failed T cell maturation, impaired B cell function, marked lymphopenia, absent thymus, no thymic shadow. Then the answer is severe combined immunodeficiency. So look for those keywords. You will find the answer. And remember the super point. The super point is severe combined immunodeficiency is a primary immunodeficiency caused by defective T cell development leading to combined T and B cell failure, absent thymus, profound lymphopenia, and life-threatening recurrent infections in early infancy. All right, folks, that's a very important topic, SCID. You will get so many questions on this topic because it is prevalent in our society. So remember this topic. Then let us go to the next one. A 45-year-old woman with long-standing rheumatoid arthritis presents with fatigue and pallor. Laboratory studies show hemoglobin 9.5 grams per deciliter, MCV 82 FL, serum iron decreased, ferritin increased, TIBC decreased. Which of the following best explains the pathogenesis of this patient's anemia? So we have like 4 options. Choose the best answer. So the best answer here is B. Increased hepcidin production by the liver, trapping iron in macrophages. Okay. Why B? First of all, think about what is the topic here. We see a 45-year-old woman, all right, a long-standing rheumatoid arthritis, all right. That's a clue to this disease. There is a chronic inflammatory disorder going on, right? And there is anemia, and iron went down, but ferritin went up. That's a nice clue there. Iron went down, ferritin went up, TIBC went down. So we are looking at anemia of chronic disease or anemia of inflammation. What in the world is this? Anemia of chronic disease is a hyperproliferative, typically normocytic or mildly microcytic anemia that occurs in the setting of chronic inflammatory states such as autoimmune disorders like rheumatoid arthritis, infections, malignancy, or chronic kidney disease. Inflammatory cytokines, especially interleukin-6, stimulate the liver to produce hepcidin, which blocks iron absorption from the gut and traps iron within macrophages. As a result, iron stores are adequate or increased but unavailable for erythropoiesis, leading to serum iron, increased ferritin, decreased TIBC, normal or mildly decreased MCV. So, ACD is not a true iron deficiency because there is adequate supply, but you can't use it. All right, it's like you're taking vitamin B12, but there are antibodies to vitamin B12, so the body is not absorbing vitamin B12. Similarly, you are taking adequate amounts of iron. You are taking iron in your diet, taking iron tablets, but still you are having anemia because that iron is sequestered. All right? So this is a functional iron sequestration disorder caused by inflammation. So remember the difference between iron deficiency anemia and anemia of chronic disease. All right, these two are different. All right, one is due to true lack of iron. The other one is due to increased hepcidin. All right, we have that is the option in our question today. Increased hepcidin. All right, so in iron deficiency anemia, we have decreased serum iron, and here also we have decreased serum iron. But in iron deficiency anemia, we have decreased ferritin, whereas here we have increased ferritin. All right. In iron deficiency anemia, we have increased TIBC, whereas here we have decreased TIBC. So there transferrin saturation went down, here transferrin saturation went up. So remember those. All right. If you remember those, you can easily get to the answer. So pathogenesis is inflammation leads to interleukin-6, increased hepcidin, decreased iron absorption, and decreased iron release, iron trapped in storage, decreased serum iron, increased ferritin, and decreased TIBC. So iron deficiency anemia, IDA, occurs when there is an absolute deficiency of iron leading to impaired hemoglobin synthesis. It is characterized by decreased ferritin, increased TIBC produced to capture iron, decreased serum iron, and microcytic hypochromic RBCs. ACD, however, is not caused by iron deficiency but by iron sequestration. Right? I told you already. In chronic inflammation, cytokines, especially interleukin-6, stimulate the liver to produce hepcidin, which decreases intestinal iron absorption and blocks iron release from macrophages. So the villain here is hepcidin. Liver is producing hepcidin, and hepcidin is decreasing intestinal iron absorption. It is blocking iron release from macrophages. And this results in decreased serum iron but increased ferritin. Iron is present but unavailable for erythropoiesis. TIBC is decreased because inflammation reduces transferrin production. So this patient's chronic rheumatoid arthritis, low serum iron, high ferritin, low TIBC are diagnostic for anemia of chronic disease. All right. So what is the mnemonic? How do you remember this? All right. The mnemonic I used is high hepcidin, high ferritin, low iron, low TIBC. That is anemia of chronic disease. So make it like a song. High hepcidin, high ferritin, low iron, low TIBC. That is anemia of chronic disease. All right. High hepcidin, high ferritin, low iron, low TIBC. That is anemia of chronic disease. All right. So anemia, hepcidin is increasing. It blocks iron release from macrophages, decreases gut absorption. Ferritin is increasing. Iron is stored. Serum ferritin decreasing, unavailable. TIBC decreasing, less transferrin produced. So remember this diagram also. All right. In anemia of chronic disease, we have high ferritin. Remember this big, huge pillar. All right. That will help you. This is the image I remembered for my exam. high ferritin. That helps you a lot. Incorrect answers. A. Decreased dietary iron intake leading to depletion of iron stores. And this is true for iron deficiency. Anemia, often caused by chronic blood loss, bleeding, menorrhagia, poor diet, pregnancy. There you have low serum iron, low ferritin, increased TIBC, increased RDW. Morphology is microcytic hypochromic anemia. Right? Iron deficiency causes microcytic hypochromic anemia. Not correct here because ferritin is increased, not decreased. And then why not C? Autoantibodies against parietal cells leading to vitamin B12 deficiency. And vitamin B12 deficiency is seen in pernicious anemia and autoimmune gastritis with destruction of parietal cells and loss of intrinsic factor. And in B12 deficiency, you see macrocytic anemia with increased MCV, hypersegmented neutrophils, and decreased B12. All right? That's not correct here because the patient has normocytic anemia with altered iron studies, not macrocytosis. There is no macrocytosis here. And what about D, point mutation in the beta globin gene resulting in abnormal hemoglobin polymerization? So that is sickle cell anemia, valine substitution for glutamic acid at position 6. This leads to vaso-occlusive crisis, hemolytic anemia, and target cells on smears. It's not correct here because the patient has no sickle cell history or features. There is no sickle cell history in this patient. This patient has rheumatoid arthritis. So this is not the right answer. Now, what about the super formula? Super formula is those few keywords you can see in a question and go to the answer direct in a few seconds, right? So if you see a patient with anemia and they talk about chronic inflammation, they don't tell you it's chronic inflammation. They tell you he has rheumatoid arthritis. He had osteoarthritis for a long time. He had some celiac disease for a long. They will give you a chronic inflammatory condition, and that's the clue. And they will tell you hepcidin elevated, and low serum iron, low TIBC, high ferritin. Then the answer is anemia of chronic disease. All right, remember those keywords, and it's very easy to point out the correct answer. What about the super point? Super point is anemia of chronic disease occurs when chronic inflammation increases hepcidin production, which traps iron inside macrophages and decreases intestinal iron absorption, resulting in low serum iron, low TIBC, high ferritin, and impaired red blood cell production despite adequate iron stores. All right, folks, extremely important because anemia of chronic disease is very common. So you will definitely get some questions. So please spend some time on this topic. Next question. A 7-year-old boy is brought to the emergency department with jaundice, fatigue, and dark urine after recovering from a febrile upper respiratory infection. His family history is notable for anemia requiring splenectomy in his mother. On examination, he has mild scleral icterus and splenomegaly. Laboratory studies show hemoglobin 9.2 grams per deciliter, low reticulocyte count 8% elevated, mean corpuscular hemoglobin concentration elevated, peripheral smear, numerous round red blood cells lacking central pallor. Which of the following is the most likely underlying defect in this patient? All right, there are 4 options here. Choose the best option. All right, this is also another important topic. All right, folks. The best answer here is C. All right. The reason is, what are we looking here? All right. First of all, think about what is the topic. All right. The topic here is hereditary spherocytosis, red blood cell membrane cytoskeleton defect causing extravascular hemolytic anemia. Hemolytic anemias are disorders characterized by premature destruction of red blood cells, leading to anemia, jaundice, splenomegaly, and an increased reticulocyte count due to bone marrow compensation. The morphology of RBCs and peripheral smear, family history, and clinical context are key to identifying the underlying pathology. All right. So, what is happening in hereditary spherocytosis? So, go from the pathogenesis. That's always the best way to study any disease. In fact, even medicine, it starts with pathogenesis. What is happening here? It's an autosomal dominant inheritance, and mutation gene for ankyrin spectral is affected. So we have these membrane proteins. These membrane proteins give strength to RBC skeleton to maintain biconcave shape. All right. So you have this biconcave shape, and these membrane proteins, they give the strength. All right. So what is happening? These membrane proteins became defective. All right. So defective membrane proteins lead to deformity and durability, of red blood cells. All right. So what is happening? This biconcave shape is lost, and there is loss of central pallor. All right. They don't tell you these are spherical cells in the question step, because that's a very big giveaway. All right. But they will tell you there is loss of central pallor, and that's a very good clue to hereditary spherocytosis. So patients get splenomegaly, they get aplastic crisis after a parvovirus B infection, scleral icterus, jaundice, indirect bilirubin, pigmented gallstones. And the treatment of choice is splenectomy. All right. In the diagnosis, you see spherocytes on blood smear, Coombs negative hemolysis, osmotic fragility test, hyperchromic RBCs with red blood cell distribution width is going up. All right. So differential diagnosis, you see in sickle cell disease, you see sickle cells. In G6PD deficiency, you see Hinge bodies. All right. These are bite cells. So bite cells are seen in G6PD deficiency. Spherocytes are seen in hereditary spherocytosis. Even a kid would tell you spherocytosis gives spherocytes, but you need to remember other things. For example, bite cells are seen in G6PD deficiency. For that, you need to memorize that. All right. Even a kid would tell you sickle cells are seen in sickle cell anemia. All right. But to know, you should learn that Hinge bodies are seen in G6PD deficiency. So in this case, the elevated MCHC and the presence of spherocytes around RBCs without central pallor strongly suggest hereditary spherocytosis. Hereditary spherocytosis is a congenital hemolytic anemia caused by defects in red blood cell membrane structural proteins, most commonly spectrin, ankyrin, band 3, protein 4.2. These proteins normally maintain biconcave shape, flexibility, and surface area of RBCs. Loss of membrane stability leads to membrane shedding, producing spherical, poorly deformable RBCs. Because spherocytes cannot easily traverse the splenic cords and sinusoids. That is the point here. Why there is a splenomegaly? Because these spherocytes cannot traverse the splenic cords and sinusoids. They become trapped and are prematurely destroyed by splenic macrophages, resulting in chronic extravascular hemolysis. Clinically, patients present with anemia, jaundice, splenomegaly, elevated reticulocyte count, increased mean corpuscular hemoglobin concentration. A positive family history and characteristic smear findings help distinguish hereditary spherocytosis from other causes of hemolytic anemia. So, how do you remember this? What is the mnemonic? What is the super mnemonic? How to remember? The mnemonic I used is Spiro. Right? Spiro from hereditary spherocytosis. And S stands for spectrin structural protein defect. P stands for pallor and anemia. H stands for high MCHC. E stands for extravascular hemolysis. R stands for round RBCs. O stands for operations. Splenectomy helps. Right? Remember that one mnemonic. In fact, you can answer a ton of questions. You can answer what is the structural defect. There is spectrin defect. There is a central pallor. And there is high MCHC. All right, that's a one question on its own. And there is extravascular hemolysis. There is splenectomy going on. That's one question. There is what is the treatment of choice? Splenectomy is the treatment of. That's another question. So there are many questions you can answer by remembering one mnemonic. All right. So how about incorrect answers? Number 1A, point mutation in beta globin gene causing abnormal hemoglobin polymerization. We have already seen this earlier. This is sickle cell disease, a missense mutation. Glutamic acid is replacing valine is going for valine at position 6, leads to hemoglobin S formation. Under hypoxic or dehydrated condition, HBS polymerizes into long fibers, distorting RBCs into sickle shapes. This produces chronic hemolysis and vaso-occlusive crisis, pain, stroke, priapism, and acute chest syndrome. However, this child's smear shows spirocytes without sickling, and his history suggests a hereditary RBC membrane disorder, not a hemoglobinopathy. And then we have B, deficiency of glucose 6-phosphate dehydrogenase enzyme in RBCs. G6PD deficiency is an X-linked enzymatic defect of pentose phosphate pathway. Reduces RBC's ability to handle oxidative stress, leading to hemoglobin oxidation. I already told you, Hinge bodies are seen here. And removal of damaged membrane. When you remove the damaged membrane, bite cells are showing up. And hemolysis is typically episodic and triggered by infections, fava beans or drugs, sulfonamides, antimalarials. And as you read through these incorrect answers, you are also learning important questions, all right? You will get these questions. Patient given sulfonamides, and what is the problem? G6PD deficiency. And this boy's hemolysis is chronic and familial with spirocytes, not episodic bite cell hemolysis. Why not D? Autoantibody mediated hemolysis with complement fixation. This refers to autoimmune hemolytic anemia, which can be warm antibody type, IgG mediated extravascular hemolysis, or cold antibody type, IgM mediated complement fixation intravascular hemolysis. AIHA can also produce spirocytes, but diagnosis requires a positive direct Coombs test. All right. So AIHA, we have positive direct Coombs test. All right. That's very important. And in hereditary spherocytosis, Coombs negative hemolysis. All right. This is a Coombs negative hemolysis. But in AIHA, you have a positive direct Coombs test. And it typically has no family history. In contrast, this child has a hereditary disorder with increased MCHC and strong family history, which favors hereditary spherocytosis over AIHA. Now, what is the super formula? Super formula is like you look at keywords and you go to the answer in a few seconds. So if a patient comes with anemia and you are seeing spectrin, ankyrin, membrane defect, that itself is, you got the answer. It is hereditary spherocytosis. But they will give you more information. They may say there are spirocytes, and they may not say spirocytes sometimes. They may say no central pallor, and they say decreased deformability. They say splenic sequestration going on. They say extravascular hemolysis going on. They say MCHC is elevated. So the answer is hereditary spherocytosis. The super point here is hereditary spherocytosis is caused by defects in red blood cell membrane, cytoskeleton protein, spectrin, ankyrin, producing rigid spherocytes that are trapped and destroyed in the spleen, leading to chronic extravascular hemolysis with increased MCHC, jaundice, splenomegaly, and reticulocytosis. All right, folks, hereditary spherocytosis, very, very, very important topic. So please take time to learn this disorder. Okay, very, very important. Next, we are going to talk about another important topic. Let us see this question. A 25-year-old woman presents with progressive fatigue, easy bruising, and recurrent gum infections over the past 2 months. Examination reveals pallor and scattered petechiae on her lower extremities. Laboratory studies show hemoglobin 7.5 grams per deciliter, neutrophil count 450 per microliter, platelet count 18,000 per microliter, corrected reticulocyte count 0.5%. A bone marrow biopsy shows cellularity less than 25% with markedly reduced hematopoietic cells and fatty infiltration without evidence of malignant cells or fibrosis. Which of the following best explains this patient's underlying condition? All right. So there are 4 options. Please take your time and give the best answer. All right, folks, the best answer here is I'm going with A. Let us see why is A. All right. Why autoimmune destruction of hematopoietic stem cells? All right, the explanation. So first, what is the topic here? The topic here is aplastic anemia, immune-mediated bone marrow failure causing pancytopenia. Aplastic anemia is a life-threatening bone marrow failure syndrome characterized by pancytopenia and hypocellular bone marrow in the absence of malignant infiltration or fibrosis. It results from failure of multipotent hematopoietic stem cells leading to decreased production of erythrocytes, leukocytes, and platelets. The condition is most commonly caused by immune-mediated destruction of hematopoietic stem cells in which cytotoxic T lymphocytes release inhibitory cytokines such as interferon gamma and tumor necrosis factor alpha. These cytokines suppress stem cell proliferation and induce apoptosis. Alright, so what are you seeing here? You are seeing here, first of all, there is replacement of bone marrow by fatty tissue. Alright, so that is the core problem. You need bone marrow, alright, because that is where you have all these cells produced. And there is replacement of this bone marrow by fatty tissue. And the red blood cells are going down, white blood cells are going down, the platelets are going down. And you can imagine what would happen because red blood cells are going down. There is anemia, there is weakness and tiredness, shortness of breath, palpitations. White blood cells are going down. There is neutropenia, fever, increased infections, diarrhea happening. There is thrombocytopenia is going on, easy bruising, frequent nosebleeds, petechiae and ecchymosis and heavy menstrual periods happening. All right, folks, so that is the basic things you need to remember. And what are the causes? There's so many causes. The anemia, the mnemonic I made it up is aplastic. Just remember that aplastic anemia comes from aplastic. A for anti-cancer drugs, anticonvulsants, acetazolamide, arsenic. P for pregnancy, paroxysmal nocturnal hemoglobinuria, pesticides. L for lupus erythematosus. A for anti-inflammatories like NSAIDs. S for sulfonamides. T for thymoma, ticlopidin. I for inherited disorders like Fanconi anemia, iatrogenic like radiation, infections like Epstein-Barr virus, HIV, hepatitis, immune thyroid disease. C for chloramphenicol, chemicals like that. Alright, there is a big list, and unfortunately questions will come even from those things like patient is taking chloramphenicol and he got anemia. What is that? That is aplastic anemia. Patient has paroxysmal nocturnal hemoglobinuria. He got anemia. What is this? Like that. So clinically, patients present with manifestations of all three cytopenias. There is anemia, neutropenia, thrombocytopenia. Now you have to remember the criteria. The diagnostic criteria is important. What makes aplastic anemia? The neutrophils less than 500, platelets less than 20,000, and reticulocyte count less than 1%. All right. So this patient meets all three criteria. That is aplastic anemia. All right. Remember that. Very, very important. And you may get questioned just by that diagnostic criteria of aplastic anemia. That's why the mnemonic here is empty marrow, NPR 500, 20,001 plus fat. All right, that is the mnemonic to diagnose aplastic anemia. There is empty marrow, NPR, N stands for neutrophils, P stands for platelets, and R stands for corrected reticulocyte count. All right, so NPR 500, 20,001. You have to remember that because that is the diagnostic criteria for aplastic anemia. So how about incorrect answers? Hypersplenism with sequestration of blood cells. Hypersplenism causes peripheral destruction or sequestration of red blood cells, like we saw hereditary spherocytosis. There we have hypersplenism. However, bone marrow is typically hypercellular due to compensatory hematopoiesis. Conditions like hereditary spherocytosis, bone marrow is hypercellular, is trying hard to put more blood cells. But here, the bone marrow, the central factory, is malfunctioning. All right, there is hypocellular marrow with fatty replacement, which rules out hypersplenism. Why not say B12 deficiency impairing DNA synthesis? B12 deficiency causes megaloblastic anemia with macrocytosis and hypersegmented neutrophils. Although pancytopenia may occur, the bone marrow is hypercellular with megaloblastic changes, not cellular. Neurologic symptoms are also common. Infiltration of bone marrow by leukemic blasts. Acute leukemia results in hypercellular marrow filled with malignant blasts, leading to suppression of normal hematopoiesis. In contrast, aplastic anemia shows marked hypocellularity with fatty replacement and no malignant cells. The super formula: autoimmune cytotoxic T cell destruction of hematopoietic stem cells. Interferon gamma and tumor necrosis factor alpha mediated suppression of bone marrow cellularity 25% with fatty replacement. As I said, neutrophils less than 500, platelets less than 20,000, reticulocyte count less than 1%, that is aplastic anemia. So you can easily diagnose aplastic anemia when you see those things. Whenever you see autoimmune cytotoxic T cell destruction, or whenever you see neutrophils, that NPR 520,001 formula I gave you. If you see those, you can easily diagnose this condition. The super point is aplastic anemia is immune-mediated destruction of hematopoietic stem cells causing hypercellular marrow with fatty replacement and life-threatening pancytopenia. All right, folks, I need to go to work, so we will stop here, and in the next episode we will continue beautiful pathology episodes. These are very, very important, and every sentence I say is loaded with important points, and these points will come in diverse forms in your examination. All right, so listen to every sentence I say carefully. Listen to every formula I say carefully. Definitely you will make a big score in your examination. All right, folks, please visit our website superpoints.ai, world's most advanced learning system to pass your examinations. All right, I will see you later.